Hear me? Can you see the screen?
Yes, we can
Yes,
see the
I will.
screen. Sir, we are able to see the screen.
Okay. All right. So this morning we are going to look at the pancreas and the spleen. These are very important organs to know about anatomically. They are frequently scanned, just like other organs. Of course, it's important to know about their structure. They can be seen on all imaging modalities. So here is big looking at these structures radiographically using different imaging modalities. So let's talk about them very fast and a few clinical correlates here and there so that we can appreciate. Okay, so of course for the pancreas we are going to look at all this, and can start right away by the introduction. Of course, we all know the pancreas. It's a gland. It's a mixed gland because it has an exocrine component and an endocrine component. Endocrine glands are glands that empty their secretions into blood. The pancreas does that. It has unique collections of cells that we call the islets of Langerhans, which specifically produce particular hormones into blood. So because of that, the pancreas can be called an endocrine gland, simply because of that. So insulin, glucagon, and others hormones that are going to be produced to go and help in regulation of blood sugar levels. Then it has an exocrine component. By definition, exocrine glands are glands that empty their secretions into ducts. Okay, and yes, it has multiple cells that are going to be doing that. They'll be producing secretion straight into ducts, and because of that, again, we can say the pancreas is an exocrine gland because of those features. So to make everything easy, you can just call it a mixed gland with all functions, the exocrine and endocrine functions. By location, of course, the pancreas is going to be lying almost horizontally on the posterior abdominal wall. We all know the posterior abdominal wall. Okay, this is the posterior abdominal wall. The anterior abdominal wall is here. This is the anterior abdominal wall. This is the posterior abdominal wall. So your pancreas is going to be close, okay, to the posterior abdominal wall. So that's where it's going to be located. And if you use the 9 abdominal regions, your pancreas is going to be within the epigastric and the left hypochondriac regions. And it's going to be lying almost oblique, okay, within those regions. So sides, the bigger part of it is retroperitoneal, meaning that it's behind the peritoneum, anchored or attached onto the posterior abdominal wall behind the lesser sac. The lesser sac, last time we said it can also be called, yes, anyone to tell us? The lesser sac can also be referred to as?
Mentabassa.
The omental bassa, okay. So your pancreas is going to be lying within these regions, the epigastric region and the left hypochondriac, specifically behind the stomach, okay. Or you can say specifically behind the omental bassa, okay, because the omental bassa is that whole space behind the stomach, okay. And we say it's going to be lying oblique, close or attached to the posterior abdominal wall. As we can see here, it's lying oblique, and this obviously shows you that the tail is more posterior. This is the This is the body. You can see the tail. The tail is more posterior because of the obliquity of this pancreas. It's going to be behind the peritoneum. This is the parietal peritoneum. And last time we said that this peritoneum is going to be almost enclosing some organs of the abdomen, like the intestines, and that's why we call them intraperitoneal. But for our pancreas, the greater part is going to be behind the peritoneum, as you can see here, and that's why we can see that it's largely retroperitoneal. It being retroperitoneal and close to the back, obviously it can help you appreciate that clinically, patients with pancreatic diseases will always experience pain radiating to the back, obviously because our organ is almost close to the back. Okay, and of course, when scanning, of course, it's important to adjust the angle and the depth of the probe so that you can easily visualize all the different parts of the pancreas. Why? Because it's deep. It's a deep organ. So you have to always adjust the angle and the depth of your ultrasound probe so that you can appreciate the parts, the various parts of the pancreas. So you say it's going to lie behind the stomach. This is the stomach. That is the stomach there. But specifically, we say it's going to lie specifically behind the lesser sac, because the lesser sac or the aumento bassa is that potential space behind the stomach. Okay, so you can say it's lying behind the stomach, or you can say it's going to lie behind the lesser or the aumento bassa. Either way, it's a correct description. The various parts of the pancreas, we have, of course, the head. The whole of this is the head. We have the neck, the body, and the tail. We are going to look at all these parts one by one and their relations. It's important to know the relations because when scanning, you can be guided in locating the various parts of the pancreas. Okay, as we shall see later on in some sonographic images. So if you look at the head, this is the head of the pancreas. Of course, it has a tongue-like extension that we call the uncinate process, as you can see. Okay, and of course, above it, we shall have the first part of the duodenum. That's the first part of the duodenum, or what we also call the duodenal ampulla or the duodenal cup. Inferiorly, we are seeing the third part of the duodenum. Okay, laterally, we have the second part of the duodenum. Anteriorly, you can see this vessel that's going down here. This is the gastroduodenal artery. This artery, last time we said it's a branch of, yes, very fast, anyone to tell us? It's a branch of, gastroduodenal artery is a branch of,
Common hepatic artery.
the common hepatic artery. So it's given off, and after being given off, it's going to run downwards posterior to the first part of the duodenum, lying in front of the head of the pancreas. Then posteriorly, of course, we have the common bile duct, as you can see there. That duct formed after fusion of the cystic and the common hepatic. It's going to lie posteriorly to the head of the pancreas, okay, to come and join with the main pancreatic to form the hepatopancreatic ampulla, which will pierce this second part of the duodenum. So those are important, very, very important relations, as we are going to later appreciate clinically when you look at the clinical correlates of the pancreas. The relations of the neck, of course, you should always remember that behind the neck of the pancreas, we have the commencement of the portal vein, or the beginning of the portal vein. It's formed by the confluence of the splenic and the superior mesenteric. and this happens behind the neck of the pancreas. Okay. Anterior, of course, we have the pylorus. You all know the stomach. The stomach has got its terminal end that we call the pylorus. It's going to be lying in front the neck of the pancreas. Okay. The body, if you look at the body of the pancreas, there are superior, inferior, anterior, and posterior relations. Of course, posteriorly, you can see that, of course, here we don't have our pancreas. It should be lying here in this concavity of the duodenum. The head lies here. The body extends towards the left side. So here the pancreas is not shown, but we can see structures that lie behind it. Okay, the abdominal aorta and the origin of the superior mesenteric artery. All these structures are behind it. Of course, we also have the splenic vein, as we are going to see. So this is the body. That's the body of the pancreas. Below, you can see you have the duodenojejunal flexure, this bend between the duodenum and the jejunum. Superiorly, we have the splenic artery. That artery is going to be a branch of the celiac trunk, remember, and it's going to extend to the left. And last time we said it has those bends within it. So that's one way how you can easily tell that this is the splenic artery. So it's going to lie superior to the body of the pancreas. Okay, so superior you say the splenic artery, inferior you have the duodenojejunal flexure, posterior you've seen the aorta and the superior mesenteric artery. The superior mesenteric vein, we said this vein is going to be coming from where? From the spleen, running behind the tail, behind the body, to come and confluence with this superior mesenteric vein at the neck or behind the neck. So you can't see the vein here fully, but it's going to lie behind the body. Actually, it's going to groove the posterior surface of the body of the pancreas. Okay, then of course anteriorly, we've already mentioned, we have the stomach, and specifically behind the stomach, we have the lesser sac. So all these two structures, they are going to be anteriorly related to the pancreas. Oh, this is important because last time we said if a patient has chronic talk about that later on. So those cystic-like structures can form within the lesser sac, and it will be an indication that this patient is having chronic pancreatitis. Okay. Then also we said, because of the fact that it lies anterior to this lesser sac, we said if a patient has chronic ulcer disease, perforations can occur and leakage of gastric contents can happen within the lesser sac. So these relations are very important to help you appreciate the clinical presentations, the clinical manifestations of different diseases related to these organs. Okay, so those are the relations of the body of the pancreas. If you look in this image, you can actually see our splenic vein clearly, but remember it is behind. Okay, that's why it's indicated with dotted lines behind the body of the pancreas. It's going to come from the drain blood from the spleen, and of course we said along its way it's going to be joined by the inferior mesenteric. Okay, in most patients that's the normal pattern. Along its way it's joined by the inferior mesenteric, but of course in a few group of people this inferior mesenteric may join at the commencement or at this a point where the portal vein is beginning from. But in most, more than 50% of the patients, this is the normal anatomical arrangement. Normally, the inferior mesenteric will come and join the splenic, and the splenic will continue to come and confluence with the superior mesenteric behind the neck of the pancreas to form the hepatic portal vein. Okay, this is the normal, the common arrangement. But of course, it's always important to know the variations because patients differ. Okay, anatomical structures can slightly be oriented differently in patients. So you should not only know the normal anatomy, but also you should also know the variant anatomy. All that can guide you and help you prevent radiological misdiagnosis. Okay, so those are the relations of the body. The tail, it's a very, very small part that is going to come and lie within the splenorenal ligament. This ligament, it's a ligament that's going to run from the spleen to the kidney, and of course within this ligament we shall have that tail of the pancreas. This ligament is connecting the spleen here with the kidney, and our tail is within it. Okay, so this tail is just close to the hilum of the spleen, and always surgically care has to be taken. Let's say if a patient is to be operated, if a splenectomy is to be done, always care has to be taken not to injure the tail of the pancreas. Okay. And also we have to appreciate that the tail is going to be the part of the pancreas that will have abundant islets of Langerhans, and if it is injured in a patient, let's say who is undergoing splenectomy, if it's injured in a patient who is undergoing splenectomy, obviously the chances of diabetes mellitus occurring in this patient is very, very, very high, because the tail is that part of the pancreas that will have abundant islets of Langerhans. Okay, so it's going to be close to the hilum of the spleen, or the mouth of the spleen, to say. Okay, the pancreas has got ducts, and we know ducts are channels through which secretions are going to pass. We can see here there are two ducts of the pancreas. We have the major, or the main pancreatic duct. This one is going to be draining the bigger part of the pancreas. It's going to be draining, or it's going to be collecting secretions from the tail, from the body, and of course you can see there are those small ducts that we call ductules. They are going to be joining this main pancreatic duct. It's going to be joining the main pancreatic duct along its way, and of course this main pancreatic duct along its way, it's going to of course have a communication with this accessory pancreatic duct. Okay, in most patients there will be that communication between the accessory pancreatic duct and the main pancreatic duct. Okay, your accessory for it, it's going to be draining mostly the head and the uncinate process. Okay, it will be collecting secretions from the head and the uncinate process, and it's going to of course have a communication, as we've said, and then later on it's going to come and join and pierce the duodenum at a very different location that's different from the location of the main pancreatic duct. So that is the opening of the accessory pancreatic duct. That opening is called the minor duodenal papilla. That's why the accessory pancreatic duct is going to pierce so that secretions can enter into the duodenum. Your main pancreatic duct, you can see it's going to join with the common bile duct, and once these two join, we form what we call the hepatopancreatic ampulla. The hepatopancreatic ampulla, and so of course some sources can call it the hepatoduodenal ampulla, always the same. It's that common structure formed once the common bile duct and the main pancreatic duct are joins. That common structure is called the hepatoduodenal or the hepatopancreatic ampulla. That ampulla, it's going to of course be surrounded by circular muscle fibers, okay, that will basically form a sphincter, sphincters that will regulate outflow of these secretions into the duodenum. Okay, so this ampulla is going to pierce this wall of the second part of the duodenum, and of course as it pierces, some part of the mucosa is going to be raised to form what we call the major duodenal papilla. This is the major duodenal papilla, That's why you shall have an orifice where secretions are going to pass to enter the duodenum, the second part of the duodenum. And of course, you can also see it here. That is the major duodenopapilla. Okay, it's going to be the entrance point for these secretions. Okay. Okay, so you've seen that these two are going to join to form the hepatopancreatic ampulla that will have circular muscle fibers that will form a sphincter around it, a sphincter that some sources also refer to as the sphincter of Oddi, the sphincter of Oddi, okay? Or you can just say the sphincter of the ampulla, okay? All those are terminologies. All right, so that's the normal arrangement of the duct system of the pancreas. That's the normal anatomical arrangement. Okay. In a few patients, you'll see no communication between the accessory pancreatic duct and the main pancreatic duct. There may be no communication. These two ducts may be separated completely, but in most patients, these two ducts will have a communication, as you can see here. Okay. So this arrangement is very, very important clinically because let's say if a patient has got a stone, a gallstone that is plugged in this major duodenopapilla, obviously you can see what will come as a result of that. Bile will not be able to go through. This bile will of course move in a retrograde fashion back into the common bile duct. Okay. And of course, there are more high chances of jaundice occurring because too much of this bile will overfill this duct, and of course, pigments from the bile can leak into the surrounding blood vessels, resulting into jaundice. But also, there's a possibility of these pancreatic secretions going back into the pancreas. Once they go back into the pancreas, there's a possibility of leakage from the duct into the parenchyma of the pancreas, leading to pancreatitis. So all those are complications that can arise if at all a gallstone plugs itself into this major duodenal papilla. Okay, so that's the duct system. Then we have the arterial supply of the pancreas. Of course, there are many blood vessels that are going to nourish our pancreas. It's a very active organ. It has many active cells, exocrine, endocrine, and of course it needs a nutritious supply of blood so that those cells can continuously be functioning normally. So you can see that there are many contributors to this: the splenic artery, the gastroduodenal artery, and the superior mesenteric artery. They all contribute towards this arterial supply of the pancreas. You can see the splenic. The splenic, we said, it's going to be a branch of the celiac trunk. Remember, this trunk has got three branches: the left gastric, the common hepatic, and the splenic. This splenic is going to have veins within it running towards the spleen on the left side. But of course, before it reaches the spleen, it's going to have many branches that are going to supply the body of the pancreas, many branches that are going to supply the tail of the pancreas, as you can see here. Okay. Then, of course, you can say gastroduodenal. It's going to have what we call the superior pancreatico duodenal artery that will divide into branches that are anterior and then posterior to supply blood to the upper part of the head of the pancreas. Then you can see our superior mesenteric. It's going to give off the inferior pancreatic duodenal artery that will also have anterior branches and posterior branches. These branches of the superior mesenteric, they are going to anastomose with these branches of the gastroduodenal to form arterial arcades that will form an anastomosis, or a loop that will always allow continuous flow of blood to the head of the pancreas. Okay, so that is the arterial blood supply. Of course, these images can further show you these blood vessels. You can see this is our splenic, that is our splenic. It's going to supply the body, as we've said, and the main branch that comes from it is called the dorsal pancreatic artery. There is what we call the greater pancreatic artery. All these are going to supply the body of the pancreas, but also we said it has branches that are going to come and supply the tail of the pancreas. Then the head, we said it has an anatomical anastomotic arcades, anterior and posterior, contributed to by the gastroduodenal and the superior mesenteric. Okay, these are going to allow you continuous nourishment of blood to the head of the pancreas. Okay, so there's something important here. This superior mesenteric here, we know that it's a branch of the abdominal aorta. Okay, it's given off just below the pancreas. Okay, just below, you can say just posterior to the pancreas specifically. As we can see, it's a branch of the superior mesenteric. It's going to be running anterior to the third part or to the inferior part of the duodenum. Okay, and you have to appreciate that there is always so much fatty tissue around it, fatty tissue that prevents this artery from compressing our duodenum. Normally there is that adipose tissue around our artery and around this part of the duodenum to prevent this artery from compressing the third part of the duodenum. There are scenarios in a few patients, patients with metabolic diseases that leads to reduced adipose tissue in these parts of the body. Such patients can have an obstructed duodenum simply because of reduced fatty tissue around the duodenum and around the artery. Okay, and basically that's called the superior mesenteric artery syndrome. It's rare, but it can happen in a few patients. Okay, so that's the clinical correlate of that. Then sonographically, we can say that our artery is surrounded by fatty tissue, and that's going to be the major important landmark or feature that can be used to tell, or what I'm looking at is the superior mesenteric artery. Okay, because around it there is a lot of fatty tissue, and we shall see how that can give you a clear picture and differentiate this artery from nearby arteries and from the superior mesenteric vein. Okay, the venous drainage is also quite direct. Of course, you can see we have what we call the superior pancreatic or duodenal vein draining the upper part of the head, and it's going to empty into the portal vein, the formed portal vein. We have the inferior pancreatic or duodenal vein draining the lower part of the head and the uncinate process, and it's going to empty into the superior mesenteric vein. Then the body and the tail of the pancreas, they are drained by multiple tributaries that are going to later come and join the spleen along its way. Here we're just seeing just one tributary, but there are quite many that are going to come and pierce or pour into this splenic along its way behind the body. Okay, so that's a venous drainage. It's quite direct. Okay. Normally, sonographically, of course, it's possible to see the pancreas. Let's say if, for example, you position your probe in a transverse manner around the epigastrium, it's possible to see the pancreas. And of course, you can appreciate it here. This is your pancreas. Okay. This is the right side of the image. This is the left side of the image. This is the anterior aspect. This is the posterior aspect. Okay, you're positioning your probe there. So obviously your abdominal is going to be the most anterior structural components. Then here we can see the shadows created by the vertebral bones. So our pancreas, you can see the parts. Of course, it's a bit faint, but yeah, you can see the parts. Okay. Of course, we have the head. Okay, around here we have the neck. That's the neck. We have the body and the tail. Okay. This pancreas, as we age, its appearance is going to be, it's going to be difficult to easily differentiate it, or to easily appreciate these parts, because remember, this pancreas doesn't have a capsule, so surrounding fatty tissues always infiltrate the pancreas, changing its appearance, and that's why it's not possible. It's possible, but of course it can be hard to appreciate these parts fully as you age, because as you age, fatty tissue is going to infiltrate into the pancreas. It has no capsule, so this tissue can easily enter it, resulting into this unique appearance. So we can see a few features. Of course, we say this is the head, this is the neck, we have the body here, and the tail. So we've already seen that around your head, there are some important relations, okay? So anteriorly we mentioned, we have the gastroduodenal artery running in front of the head, okay? Posterior, we have the common bile duct, if you remember. So of course, this is the anterior aspect, posterior aspect. So that structure that you see there is the gastroduodenal artery. That structure that you see here is the common bile duct, okay? Of course, to prove this, a Doppler ultrasound can be used to confirm if this is a vessel. If there is flow, obviously you confirm that this is your gastroduodenal artery. There will be no flow here, okay? So that's what can be used to differentiate these two. Then posterior to the head, of course, we mentioned structures like the inferior vena cava, okay? Then, of course, posterior to the neck, importantly, we said the portal vein is going to be forming. How is it formed? The splenic joins with the superior mesenteric. This is the meeting point, okay, to form the portal vein. And you can see our splenic there behind the body, and then that is its meeting point with the superior mesenteric vein to form the hepatic portal vein behind the neck of the pancreas, okay? Of course, the tail can also be appreciated here towards the left side. That's the tail there. Okay, the abdominal aorta, we said it's posterior. You can see it posterior to the body here, okay? And of course, we have our superior mesenteric. It's that unique artery surrounded by fatty tissue. This bright tissue that you see here is fatty tissue, okay? It appears bright on ultrasound. It's going to be surrounding this vessel, the superior mesenteric artery, okay? There was a hand from someone, I don't know who. I heard as if someone is raising a hand. I don't know if... I think there was no question. I can see here in the chat, people are saying the presentation is not displaying. Is it a general problem to everyone?
No,
Yes, sir.
it is displaying.
Okay. So if it's not displaying, you can try to refresh and then you can get back. Okay, so this is another sonogram showing us the pancreas, okay? If you position your probe in a transverse manner, as you can see here, the same orientation will be the same orientation here. Of course, towards the right side, you have the head, the neck around here, the body, and the tail. So we've mentioned already that behind the head, obviously the obvious structures that can be appreciated is the IVC behind the head. Of course, we have other structures here alongside the head, though here they are not labeled, but of course we have the gastroduodenal artery around here, and then the common bile duct posterior to the head. Then we said behind the neck, that's where we shall have the commencement of the portal vein, and we said this portal vein is formed by the union of the splenic that is running behind the body. It joins with the superior mesenteric vein to form the portal vein. And then we said behind the body, of course, we have the abdominal aorta, and of course we also have the artery that we call the superior mesenteric artery, distinguished by its unique relationship with this fatty tissue. Okay, it's around it, and it makes it appear, it's going to appear bright around our artery. Then of course the tail, you can see it there. In this image, there is something unique that you have to appreciate. There is some part of the splenic artery that is seen within the pancreas. Now, this sometimes can confuse, but you have to remember that your artery has a tortuous course. It has veins within it. It has veins within it. So, if at all, let me illustrate this. Let's say this is your pancreas, and this is your artery. It has veins along its course, as you can see. It has veins along its course. So because of the tortuosity or the veins, it's possible to see part of the artery, okay, and this artery will appear as if it is within the pancreas. As you can see here, this is the part of the tortuous splenic artery, okay, within the pancreas. It's appearing because our artery has those veins within it. Normally those veins have to be there because we know that there's a stomach in front here. This stomach is always going to be distended. So of course, to prevent this vessel from easily rupturing, of course, normally, naturally, it has to have those veins within it. So that even though the stomach distends, this vessel, this artery will not be affected. So those veins, normally, they should exist within it or along its course. Okay, these images are also showing us the pancreas. Of course, we are scanning the head, as you can see. Of course, we shall also see part of the body and the tail. Of course, anterior we have the abdominal wall. Remember, the abdominal wall and some structures. And you can see our pancreas. We have the body. Okay. Sorry, we have the head here. We have the body there. We have the tail. The relations are almost the same. You can see the body here. Behind it, we have the splenic vein. Behind it, we have the abdominal aorta. Behind it, we have the superior mesenteric artery. That artery there, the bright tissue around it. Posterior to the head, of course, we mentioned, we have the inferior vena cava. Okay. In this image, you can see we are going more to the left. You can still see part of the head of the pancreas, and then you can see more of the body of the pancreas. And behind it, we've already mentioned, we have the splenic vein. You can see it in a better shape here. Okay. The abdominal aorta, the superior mesenteric artery, all those are relations of the body of the pancreas. Then in this image, we are still seeing the same structures. The splenic vein behind the body. The splenic vein is a very important relationship. It can easily tell you the part of the pancreas that you're focusing at. We know it's behind the body. So seeing it, obviously you can conclude that what I'm seeing here is the body of the pancreas. Okay. Behind it, we have the superior mesenteric artery, abdominal aorta. All those are important relations. In these images, we are scanning in a sagittal plane. Okay, so you can see if you scan in the sagittal plane to observe the head. Yes, you see the head in that sagittal orientation. And of course, you can still see the relations behind it. We have the inferior vena cava. Okay. We know that just adjacent to it, we have the duodenum. So you can see part of the duodenum close to the head on the right side. And of course, we know that usually intestinal structures on ultrasound, they are going to appear with gas within them. So you can see those that gas within the duodenum. Okay, so these relations are very important, and all these images are further showing you the relations. Of course, we are still scanning the pancreas in this image. You can see we are focusing around the neck. That's the neck of the pancreas. Behind it, we have the superior mesenteric vein coming in to join with the splenic. Okay, here you can see the splenic. Remember, we are orienting our probe in a sagittal manner. Our splenic is running in a transverse orientation. So in this scanning plane, you can only see the superior mesenteric what? Vein. Remember, this vein is running downwards. It's running downwards, as you can see in this small image here. So if you position your probe in such a sagittal scanning plane, obviously you'll see it running behind the neck of the pancreas. Okay, so in this image, we can still see the structures behind the neck. Again, that's your neck there. You can see the superior mesenteric vein. You can see superior mesenteric artery. The vein, we've already identified it, the artery. In this longitudinal view, you can see it coming off from where? Coming off from your abdominal aorta. This is the abdominal aorta, and you can also see it here, giving off that superior mesenteric artery, an artery that's going to be running downwards. And of course, we say there's fatty tissue around it, and that's why its outer wall is appearing bright. That's a feature that I mentioned that can be used to differentiate this artery from the vein. Okay, so basically those relations are all very important for you to know about. Okay, so all these images are almost similar images showing us the relations of the pancreas. Okay, let's focus more. You can see the probe is positioned almost close to the neck, and of course we said that around the neck of the pancreas we shall have the splenic vein joining with the superior mesenteric vein, but also we have the superior mesenteric artery posteriorly surrounded by that bright fatty tissue. Okay, this is the abdominal aorta. Okay, as you move towards the left side of the body, you'll see more of the body of the pancreas. The vein, the splenic vein is posterior to it. The splenic artery is going to be along its upper border. How can we differentiate these two? Or is the veins are larger? Veins have a wider lumen, remember, so the vein is larger than the artery. Okay. In this image, of course, we are scanning the, we are positioning the probe towards the left side of the patient, and of course, you're going to be seeing the tail. The tail of the pancreas, you can see it's going to be lying almost adjacent to the left kidney. And in this scanning plane, the left kidney will come into view posterior to the tail of the pancreas. Okay. Then also you can see your vessels that are associated with the pancreas. They can also be seen along the tail. Our vein, remember you say it's larger or is larger than the artery, so that's how you can differentiate them. Then behind here, the whole of this is the left kidney. Okay, so with all those features, relations, it's possible to identify the pancreas. There's no way how you can confuse it with the surrounding structures. If you know the parts, if you know the relations, you can easily appreciate it well. How does it form? It's very easy and simple. These images can make it very, very clear for you. Okay, you can see in this image we are seeing a growing embryo. This may be around week 4, week 5. Okay, you can see the growing alimentary canal, what we call the primitive gut tube. Okay, it's going to be giving off very many structures. There's a lot of structures that will be derived from this gut tube. Okay, the foregut here will give off many structures. We've been looking at these structures in embryology. This is the mid gut portion that is in communication with the yolk sac, and then down here we have the hind gut. Okay, so now your pancreas, it's going to arise from the foregut. This is the foregut, remember. You can see along the wall of the foregut, from the anterior and the posterior aspect, we shall have those outgrowths, or you can call them outpoachings, or you can simply call them buds. We have the ventral pancreatic bud and the dorsal pancreatic bud. Okay, all these are going to be formed from the endoderm that is lining this foregut. Okay, we say this is the foregut. We have the midgut here, we have the midgut there, and the hindgut. Out of all these, this ventral bud is going to be close to the midgut. Okay, and that can make you appreciate the reason as to why the pancreas is not only supplied by the attar of the foregut, the celiac trunk, but also it's supplied by the attar of the midgut, because in development, part of it, it's going to develop close to the midgut. So that embryological pattern can help you remember the blood supply easily. So the ventral bud, of course, it's called ventral because it will be an outpoaching on the ventral side of this gut tube, as you can see. And then the dorsal pancreatic bud is called the dorsal bud because it's going to be an outpoaching on the posterior, or on the dorsal side, or on the dorsal surface of this gut tube. Okay, these buds are going to form around the 5th or 6th week of development, and of course, as development continues, normally we know that the stomach has to rotate. Okay, if you look at the normal human body, the stomach is more on the left, so normally it has to undergo rotation. The duodenum is more on the, it's going to be a loop on the right side of the abdomen. So normally these structures have to undergo rotation. As these structures undergo, as this gut, part of the gut undergoes a rotation, these buds are also going to change their position. As you can see, as the duodenum undergoes rotation, as it becomes C-shaped, these buds are going to change position. Mostly this one here, this ventral pancreatic bud, it was on the ventral side, but because of the rotation of the duodenum, this bud is going to take a turn to pass behind the growing duodenum to come towards the left side and fuse with its counterpart, the dorsal pancreatic bud. These two fuses after this ventral bud rotating around the duodenum to come on the left side. Okay, that rotation normally has to happen during the process of rotation of this part of the gut tube that will form the duodenum. Okay, so these buds, after rotating, of course, they are going to continue growing, and of course, they are going to start fusing together, as you can see. They are going to start fusing together, okay? And as they fuse together, obviously, you can appreciate that this ventral pancreatic bud, this one here, it's going to form, it's going to be the one that will form the head and the uncinate process of the pancreas, okay? This dorsal pancreatic bud is going to be the one forming the body and the neck, the body and the tail of the pancreas. So that's where those various parts are going to be derived from. Okay. So that's how normal development happens. This image can further show you this is your ventral bud, dorsal bud. As the duodenum rotates, this ventral bud is going to rotate around the duodenum to come and fuse with its counterpart so that we can form the gland. Okay. Of course, as the various parts of the gland forms, the ducts are going to also be forming. Okay. Initially, we have two ducts. We have a duct of the ventral bud, the duct of the dorsal bud. So as the various buds fuse, the ducts are also going to start fusing. Normally they fuse. Okay. And of course they fuse so that we end up with the main pancreatic duct, okay, that will be draining or that will be collecting secretions from the bigger part of the pancreas, and then this small accessory pancreatic duct that will be draining or collecting secretions from the head and the ascending process of the pancreas. Okay, so that is part of normal development. Okay, so of course as those buds grow, the various connective tissue elements of the gland are also going to be forming. Okay, the parenchyma of the gland is also going to be forming. Okay, the parenchyma of the gland is going to arise from the endoderm of those buds, the ventral and the dorsal buds. The endodermal tissue of these buds will form the parenchyma. By parenchyma, we mean the functional part of an organ. Okay, that part that will be functioning, or that will be responsible for the normal functioning of the organ. The parenchyma of the pancreas consists of things like the islets of Langerhans. You know, there will be the structures that will later form the what? Later form the give rise to cells that will help in production of insulin and glucagon. So that parenchyma is going to be derived from the endoderm of these buds. Okay, but we said these form more in the tail. I talked about that they form more, they are abundant in the tail of the pancreas. Connective tissue elements of the pancreas, for example, the blood vessels and other structures, that are going to come from the surrounding mesoderm. Remember, we have three germ layers. We have the endoderm, which is the innermost. Okay, that's the endoderm there. It's the one that forms our buds, those buds that you see there that are growing out. Then the surrounding tissue is the mesoderm, or you can say mesenchyme. So that surrounding tissue, it's going to form the various connective tissue elements, for example, the blood vessels that will be supplying this pancreas. Okay. Then, of course, as the buds grow, there are some portions of the buds that will form ducts, as we said. The ducts within are going to grow to give rise to the main and the accessory ducts. And then it's important to also note that there are some special cells that will form later in development. These are the cells that will form these round structures that we call the acini. These acini are going to be the structures that will help in production of different contents of pancreatic juice. We know that normally the pancreas has to produce pancreatic juice, and it's going to be formed by these simple cuboidal cells that will be lining your ducts. Okay, these cells are going to be oriented in a round fashion to form structure that we call acini, and these cells will always be producing contents of the juice, the bicarbonate ions, the various enzymes, to be transported through the ducts towards the duodenum to always help in digestion. Okay, so basically that is how the pancreas is going to form. Okay, that's how the pancreas is going to form. There are a few anomalies of the pancreas that are clinically very important. The most clinically relevant anomaly is the annular pancreas. This is very, very important to know about because it leads to many complications. And we can see how it comes about in this image here. We said normally during development, there is formation of the ventral bud and the dorsal bud. We say that normally the ventral bud has to rotate towards the left side. Okay, it rotates around the duodenum to come on the left side to fuse with its counterpart to form the gland. In some abnormal cases, the ventral bud can bifurcate, form two leaflets, and once the time of rotation reaches, or during rotation, normally these leaflets are going to move to opposite directions, and once they move to opposite directions, you can see they are going to surround the second part of the duodenum. As they surround the second part of the duodenum, that part of the duodenum is going to become underdeveloped, resulting in what we call duodenal atresia. It's going to be underdeveloped and almost fully obstructed, resulting into what we call duodenal atresia. Okay, and same thing can be seen here. That's pancreatic tissue surrounding the second part. That's obstructing our second part of the duodenum. It's going to be obstructed, and these young ones always, whenever they eat any meal, they are going to be vomiting, okay, because of the obstruction of the gut tube here. It's going to be obstructed, and of course, radiographically, you'll see what we call the double bubble sign, okay. If these units are examined by X-ray, you'll see what we call the double bubble sign. This is a sign basically showing you a bubble of the duodenum and a bubble of the stomach. Normally, we know that the stomach can contain gas, but also the duodenum can contain gas. This gas comes from where? Whenever you eat, some air enters into your alimentary canal. But also, we have bacteria that always carries out fermentation, resulting into gas production. So that's why most cases your gut will have gas within it. But now, in this case, you're seeing an unobstructed duodenum, and gas bubbles are going to be seen only in the stomach and in the duodenum. There's no gas bubble down here because there is an obstruction. And this will give us what we call the double bubble sign. That double bubble sign, it is pathognomic for duodenal atresia. Okay. Of course, on ultrasound, this condition can still be appreciated. This is your pancreas. Of course, we said on its right lateral side, we have the duodenum. Okay, so in this case of annular pancreas, you see the pancreatic tissue surrounding that duodenum. Okay, it's making a sling around it. Resulting in what we call annular pancreas. Okay, so that is the most relevant congenital abnormality of the pancreas. There are many others, but this is the commonest one. It is possible to have pancreatic tissue deposited in different parts of the body. Okay, those tissues are called ectopic pancreatic tissues or ectopic pancreas. They can be deposited in the different submucosa of different parts of the body, of the abdomen. Mostly the duodenum, the stomach, all these parts, they can have pancreatic tissue deposited within them. It's an abnormality, okay? And of course, it can result into, of course, complications. One, let's say if that pancreatic tissue is plugged in any of these, let's assume if this patient, for example, has got pancreatic cancer and in some part of the pancreas, and let's say after surgery that part is removed, there will be possibility of this cancer to recur because there will still be some remaining pancreatic tissue in different parts of the body without you knowing. Okay, so that's why it's always important to always critically examine the body structures, in that if there is any abnormal mass or abnormal ectopic tissue that's not similar in structure with that tissue, that organ, or is that has to be reported, because usually such ectopic tissues can of course result into complications. For example, in patients with cancers of such organs, if such cancers are managed, those patients will not completely heal, because there'll be still some tissue residing in other parts of the body. It could be any part of the body from this list. Okay. Then it's also possible for this ectopic pancreatic tissue to result into what we call an intersusception. Okay. Whenever this tissue plugs itself into the wall of, for example, the duodenum, or let's say the ileum, mostly the ileum, if it plugs itself in the ileum, it can easily result into what we call an intersusception. Last time we described what an intersusception means. Okay, this condition occurs when one part of the gut abnormally enters or telescopes into the adjacent part of the gut. As you can see here, this part of the gut is abnormally entering this other portion of the gut. Okay, there are many risk factors to this, as we explained last time, but additionally, if a patient has any ectopic tissue in the wall, it can increase chances of this condition to arise. Because whenever peristalsis goes on, we know that these walls are going to be moving, okay, and because of that tissue that is protruding into the lumen, this peristaltic wave can easily result into this part of the gut to enter into this adjacent part of the gut, as you can see here, and this leads to an intersusception, one of the causes of small bowel obstruction. Okay, so I won't go into depth of all this because it was explained in detail in previous lectures. Okay, so just briefly, pancreatitis, of course, just from the name you can tell, inflammation of the pancreas. What can cause this inflammation? If a patient is a chronic alcohol a drinker, or let's say if a patient has got gallstones, this condition can arise. I told you that if stones block this outflow, the juice will go back into the duct, and there will be a very high chance of that juice to leak. Remember, it contains enzymes. Those enzymes can cause autodigestion and inflammation of this pancreatic tissue. Okay, these patients will have severe pain in the epigastric region, and this pain will be radiating to the back, as we explained earlier. Why? Because our organ is retroperitoneal. Of course, patients with chronic pancreatitis, it's possible to have calcifications in the pancreas. Remember, your pancreatic juice has got different salts. Those salts can clump together and, of course, form stones or calcifications in the duct, but also in the pancreatic tissue. Okay, because imagine if this outflow is blocked, contents in this juice are going to concentrate, leading to such complications. Since our gland doesn't have a capsule, it's possible for pancreatic fluids to accumulate in a cystic-like structure, and this structure can easily burst, leading to leakage of this fluid into the peritoneal cavity. Okay, and this will cause peritonitis. Okay, if it doesn't burst, of course, on examination, you'll see a pseudocyst in the omental bursa. This is the omental bursa, this space between the stomach and the pancreas. So there will be an enlarged cyst that is extending into the omental bursa. All these are features of chronic pancreatitis. Okay, so we've seen many pictures of ultrasound showing us the pancreas. There is this CT image. It can also show you the pancreas. Okay, so it's possible to appreciate the different parts of the pancreas, the relations. Okay, they are easier It's very easy to appreciate them on the CT scan. Of course, you can see behind the body we have the splenic vein that's going to join with the superior mesenteric to form the portal vein. Okay, among other relations which I don't want to repeat. The abdominal aorta is behind the pancreas. The left kidney is behind the tail of the pancreas. Okay, all these I don't want to repeat. We've already talked about them. So in a patient with pancreatitis, of course, there will be signs of inflammation of the pancreas. Okay, here you can see a pancreas that's affected with pancreatitis. You can even barely see the borders. In this image, you can't see the border. In a normal patient, you can see the borders of the pancreas. But if there is chronic pancreatitis, the margins of this organ cannot be well appreciated. That's a sign that there is chronic injury, chronic inflammation going on. Okay, and we said it's possible to have stones within the gland in patients with chronic or long-standing pancreatitis. Pseudocysts can form in patients with chronic pancreatitis. Okay, then lastly, in some patients with pancreatic cancer or with a high predisposition to tumors, such patients can have tumor masses in the head of the pancreas. This is the part of the pancreas that is highly predisposed to having tumors within it. And once tumors form in the head of the pancreas, you can see many structures that will be obstructed. And these can explain to you why such patients will present with these signs and symptoms. Patient can present with jaundice because the bile duct is obstructed. Bile is going to accumulate in this common bile duct, and it's long-term obstruction can lead to leakage of pigments into the surrounding blood capillaries, leading to jaundice. If there is obstruction of the duodenum, of course, there will be this patient will present with vomiting because of the what? The obstruction of the duodenum. The contents will not easily be going through. Okay, so that's the duodenal obstruction. This patient can present with ascites because the portal vein behind can easily be compressed. Remember, it is behind the head of the pancreas. It can be compressed, leading to increased portal hypertension, and we know that is a precursor of ascites. Okay, as we explained last time. The IVC can be obstructed, and that can lead to edema in the lower extremities. So with the relations in mind, you can easily appreciate why such patients can present with all these clinical signs and symptoms. Always and always, the patient's clinical presentation can easily guide you before even you start scanning. Okay. All right, so that was the first part of the lecture. It was mainly concentrated on covering the pancreas. In the same lecture, I had planned to cover the spleen. I don't know if it has been covered by the bachelor student, but if it's already covered, you are free to I can say to leave the session, and because it's already covered, so no need to repeat. But for the diploma students, of course, you have to remain because we had not yet covered this. Okay. So before I continue with the spleen, do we have questions regarding what we have just explained? Just a few questions, then we continue. Yes, Moses, very fast. Maiga Moses, your hand is up. You have a question?
Yes, sir. Thank you, doctor. I am requesting to know, is it true that the right gastro-omental vein is a branch of the splenic vein, or it's just anastomosis with the left gastro-epiclotic vein? which is the branch of the splenic vein, because you see in the venous supply there is somewhere the distal part, that's where the right gastromental vein is. Then the proximal part to the splenic vein, that's where the left gastroepiplotic vein is. So, which is the right statement?
Okay, so before I answer, let me just correct you briefly. In your question, you said, is the right gastromental vein a branch of? Before even continuing, that statement is not correct, because veins are tributaries. They are not branches, they are tributaries. Okay, so can you kindly rephrase your question using the word tributary so that I can easily answer your question? Rephrase your question, Moses.
Is it true that the right gastromental vein is a tributary of the splenic vein, or it's just anastomosis with the left gastroepiplotic vein, which is another tributary of the splenic vein? Because when you see the image clearly, there is somewhere whereby the distal end of the right gastromental vein is going to meet somewhere with the left gastroepiplotic vein, which is just proximal to the splenic vein. That's the question.
Okay, so your question is about veins, but to make you understand, let's go back to the arteries. So Moses, where does the right gastro-omental artery arise from? Where does it arise from? The right gastro-omental.
The right gastro-omental artery arises from the hepatic portal artery.
Moses, there is nothing like hepatic portal artery. Moses, I think there are a few details that are confusing you, but anyway, to make a direct answer to this, the right gastro-omental vein, it's going to be pouring into the superior mesenteric vein, and this blood will enter the portal vein, because this superior mesenteric vein will later join the splenic. Okay, so the right gastromental, it's a tributary of the superior mesenteric vein. It pours into that vein. Then the left gastromental vein, it's a tributary of the splenic. It pours into the splenic, close to the splenic hilum. Though I don't have these pictures here because I'm not planned of talking about those veins. But let me hope you're getting a picture in your mind, Moses. Moses, are you getting a mental picture of what I've said?
Yes, sir, I'm trying to pick it.
All right, so don't confuse those arteries with veins. Always have clear detail of those different distinctive structures, because all these vessels, you always be appreciating them sonographic, and you shouldn't always confuse them, because you make mistakes. Last question from Zakaria.
Yes, sir. I would like to know what the difference between the ampulla of Vata and the hepatic pancreatic ampulla.
The hepatopancreatic ampulla is the same as the hepatoduodenal ampulla and is the same as the ampulla of Vata. Is that clear?
Thank you, sir, for the clarification. Yeah.
All right. Okay, so let's proceed. Cover the spleen for these few remaining minutes to 9. So the spleen is a very important organ of the body. There are a few details that you have to appreciate. Of course, it lies in the left hypochondriac region between the fundus and the diaphragm. Okay, you can see the spleen here. You can see the fundus of the of the stomach, and the diaphragm lying behind. So it's lying between the fundus of the stomach and the diaphragm posteriorly, and it's going to be adjacent in close proximity to rib number 9, rib number 10, and rib number 11. Rib number 9, 10, and 11. Those three ribs are going to be running along its longitudinal axis. They are going to be close to our spleen. Okay. The spleen is going to vary in position in different phases of breathing. When you breathe in, the diaphragm is going to be pushed down, and your spleen is going to descend downwards slightly because of this diaphragm that is going to be descending during inspiration. And that's why during the scanning process, it's always important to tell the patient to take a deep breath and hold for a few seconds, because once the patient does that, this organ of interest is going to lie slightly beneath these ribs, and you can have some clear visualization to that spleen. Okay. Of course, it won't, of course, descend far away from the left costal margin. It will descend slightly away from, just slightly away from the ribs. Okay. It's an ovoid organ, purple in color, about the size of your fist. These are very important measurements to always remember. The thickness is about 1 inch. 1 inch is about 2.5 centimeters. Okay. Then the breadth or the width is about 3 inches. The length is about 5 inches. This is close to 12.5 centimeters. The length from the top to the bottom, that craniocaudal length, it's about 5 inches or 12.5 centimeters. It can increase in a patient with splenomegaly. Okay, so if the craniocaudal dimension, if the length of the spleen of a patient is more than, let's say, 13 centimeters, that may be a sign that there is splenomegaly. Okay, it's going to be enlarged. Normally, you can't palpate the spleen, but if it's enlarged, you can even start feeling it beneath the left costal margin. If you tell the patient to take a deep breath, you can easily feel the bigger part of the spleen on palpation. Of course, the weight, about 7 ounces. This is around 200 grams. Okay, so these odd numbers, 1, 3, 5, 7, 9, 11, they can easily help you remember these few details of the spleen. The features of the spleen, of course, there are two ends, the anterior, posterior, two borders, superior, inferior, and two surfaces of the spleen, all which can be appreciated here. Okay, so you can see the ends. There is the this anterior end and the posterior end. Anterior meaning it's more oriented anteriorly than this one. This is pointing to the back. It's more oriented posteriorly. This is pointing anteriorly. So this is the anterior end, and this is superior. This is the posterior end. Okay. This posterior end can also be called the medial end because it is close to the midline. It can also be called the upper pole. Okay. Then this anterior end can also be called the lateral end because it's more periphery, and it can also be called the lower pole. Okay, so all those are different terms that can be used to name these ends of the spleen. Okay. Of course, you can see what we've just said. Our spleen is going to be located between the fundus of the stomach, though here your stomach is cut out, but it's going to be between the stomach and the diaphragm, which is separating it from our ribs, rib number 9, 10, and 11. Okay. The anterior end is going to be adjacent to the splenic flexure. The splenic flexure, what we call the left colic flexure. Then the posterior end is going to be close to the upper pole of the kidney. We have the kidney around here, though it's not labeled. This kidney is going to be close to this end, this posterior end of the spleen. The surfaces, those are basically areas, external areas of the organ, okay? You can see the whole of this irregular surface is called the visceral surface. It's irregular because there are many organs that are close to it, okay? That surface there that is facing the organs is the visceral surface, okay? It has different impressions because there are different structures that are going to be close to the spleen. You can see the left kidney, as we've mentioned, it's going to be close to the spleen, so there will be a renal impression, okay? Then, of course, your fundus of the stomach is going to be running along this area here. So that fundus and the body of the stomach, they will create an impression that we shall call the gastric impression. Then the left colic flexure, it's just inferior, and it's going to also create an impression that we shall call the colic impression. Your pancreas, we say the tail is going to be close to the hilum, and yeah, it may create some impression or not, but all these are impressions that can easily help you remember the visceral relations of the spleen. Then this other external area, this is the diaphragmatic surface. It's called so because it's going to be in close contact with the diaphragm separating it from the ribs, okay? One thing that I had not mentioned, we also have borders, okay? I already talked about the ends, okay? I've talked about the surfaces, but also we have borders. The spleen has got borders. You can see this is your superior border, or you can call it an anterior border, this one here. Then there's another border that you can't see, it lies below. It's called the inferior border. This one here, it's the inferior border. This inferior border is going to be separating the visceral surface from the diaphragmatic surface medially. This anterior border or the superior border is going to be separating the visceral surface from the diaphragmatic surface laterally. Important to note, this anterior border is going to be notched because later we shall learn that this spleen during development, there are different tissues that come close to form it. So because sometimes there's a possibility of these tissues not to fully fuse together, there's a possibility of having some bit of depressed areas along the anterior margin or along the superior border of the spleen. And those depressed areas are called notches, okay? They are important during clinical examination because whenever the spleen enlarges, okay, and then you try to palpate, you can feel these notches. That can help you differentiate a patient with an enlarged spleen and a patient with an enlarged kidney, okay? That can help you differentiate. If the patient has an enlarged spleen, that spleen is going to bulge outwards and you feel notches along its anterior margin, okay? Those notches form as a result of incomplete fusion of the tissues that form the spleen. The spleen is always supported in position by help of ligaments. There's what we call the gastrosplenic. That ligament, the gastrosplenic, you can also see it here, gastrosplenic, okay? You can also see it here. It's going to be connecting, or it's going to be extending from the hilum of the spleen to the greater curvature of the stomach. And it's going to be containing the short gastric vessels, okay? There are those short gastric vessels, around 3 to 4, that always come from the splenic artery to come and supply the stomach. If you remember the blood supply of the stomach, there are those short gastric arteries that always rise from the splenic artery to come and supply the stomach. They are going to be running through the gastrosplenic ligament. That ligament there connecting your stomach to the spleen. Then you have the lienorenal ligament or the splenorenal. The word lien also means spleen. So the lienorenal ligament is also called the splenorenal ligament. It's going to extend from the hilum of the spleen to the anterior surface of the left kidney. okay, from the hilum of the spleen to the anterior surface of the left kidney. So you can see it here. This is the linearenal ligament. You can also see it here. This ligament here is the linearenal ligament extending from the spleen towards the anterior surface of the kidney. It's going to be containing, of course, the tail of the pancreas, as we explained in the previous session. The tail of the pancreas is going to be within this ligament. The splenic vessels, the artery and the vein, they are going to be within this ligament. And the pancreatic or splenic lymph nodes, those lymph nodes that drain lymph from the spleen, they are going to be within this ligament. So these are basically supporting structures, the structures that keep your spleen in position. The spleen is nourished by the splenic artery, and this is a branch of the celiac trunk. The celiac trunk, it's that short vessel that arises from the anterior surface of the abdominal aorta. And after rising, it has only 3 branches. The common hepatic, the left gastric, and then your splenic. That one there. We say this has a tortuous course. It has bends along its course, as you can see, because we said normally the stomach during expansion, it of course will not affect our artery. If our artery didn't have this tortuous course, it could easily be torn, or it could easily rupture whenever you eat large amount of food, because whenever you eat large amount of food, the stomach can distend and it could injure our artery, but normally it cannot injure it because our artery has bends along it that can allow it to stretch, minimize injuries. Okay, so that's the splenic artery. It's going to go towards the hilum and divide into branches that will enter into the spleen. Okay, this artery, in most of the patients, 90% of the patients, it's going to be a branch of the celiac trunk. In a few patients, it may be a branch that is coming off directly from the abdominal aorta. This is a variation. This is a variation. The splenic vein. This, of course, is going to be draining your spleen. It's formed at the hilum after fusion of different tributaries that are collecting blood from the spleen. All those are going to, of course, emerge from the spleen and form the splenic vein that will run posterior to the tail and the body of the pancreas. And we said that this vein is going to receive tributaries from the pancreas, tributaries from the short gastric veins, tributaries like the left gastroepiploic. Okay, this is what I have answered shortly. Someone was inquiring. This left gastroepiploic or the left gastromental vein, it's going to be a tributary of the splenic vein. Okay, as you can see here. Okay, then the right gastromental, it's a tributary of the superior mesenteric vein. This further answers a question that was posed by someone. Okay, so our vein, you can see along its path, it's going to also receive the inferior mesenteric, and later it will join with the superior mesenteric vein to come and form the hepatic portal vein. The hepatic portal vein, we know it's a vein that's going to take nutritious for nutrients towards the liver. Nutrients that have to always go to the liver so that metabolic processes can take place. Okay, so internally, your spleen has a unique arrangement. Okay, it has a unique arrangement, and we can appreciate that unique arrangement. But before you go to that unique arrangement, you have to appreciate that your spleen is an intraperitoneal organ, meaning that it's almost covered by visceral peritoneum. But beneath that visceral peritoneum, we have a capsule. We have a capsule that's going to be wrapping around the spleen. This capsule, it's going to consist of fibroelastic tissue and also myofibroblasts. These myofibroblasts, they are special cells that will always allow your spleen to contract slightly in in situations of hemodynamic stress. For example, if there is a excessive loss of blood, okay, these cells can contract to make your spleen push some blood that it contains to go and help in supplying other parts of the body. Okay, so those cells always help in the contraction of the spleen. Then we have the fibroelastic tissue. This fibroelastic tissue is going to be a tissue that will be within the capsule, and it's just for basically protective purposes. Okay. Your capsule, you can see it has extensions into the substance of the spleen. These extensions are called the trabeculae. These trabeculae, they are going to come into the substance of the spleen and then divide your spleen into compartments. The compartment that we call the red pulp and the white pulp. These are functional units of the spleen, and they can help you understand the function of the spleen. Okay. The white pulp, just as here the name white, it's going to be that area which is going to contain immune cells. Okay, so you can see normally we've explained that our splenic artery, as you can see here, it's going to divide at the hilum to give off branches. These branches that are going to be given off, they are called trabecular arteries because they are going to be going through the trabecula. Okay, so those trabecular arteries, they're going to come and enter into the substance of the spleen and then give off small branches like what you see here. These small branches, these small branches, these small branches that we call the central arteries. These central arteries, they are going to be surrounded by a layer of immune cells. That layer of immune cells, it will be called the periarteriolar lymphoid sheath. This periarteriolar lymphoid sheath surrounding the central arteries is going to be containing T lymphocytes. The abundant T lymphocytes that will make up this sheath. This sheath, it's what you see here surrounding these central arteries. Okay, and this sheath close to it, of course, we have different other immune cells like the B lymphocytes. Okay, in these follicles that you see here, all these germinal centers that you see here, they are going to contain B lymphocytes. But this sheath here that you see is going to only contain T lymphocytes. Okay, so obviously the relevance of these T lymphocytes and the B cells, they are important in capturing what? Capturing different pathogens that are going to be destroyed within the spleen. That's why we say that the spleen has an immune function. It has those special arrangement of cells that will easily destroy pathogens that are coming towards the spleen through this blood in the central artery. Pathogens like viruses, bacteria, they are going to easily be targeted by those cells. Okay, so basically your white pulp, it's going to be important in immune surveillance. It's going to be important in targeting pathogens. Okay, then we have the red pulp. The red pulp, what is it made up of? The red pulp, as you can see, all these centers, all these areas that you see here, these brown areas, this is the red pulp. It makes up the largest portion of the parenchyma of the spleen. The white pulp, there are only these small areas here. Okay, these small areas that you see here around these central arteries. Okay, and we say the relevance is immune surveillance. Then the red pulp for it, you can see it has a wider area, and this red pulp, it's going to contain what? It's going to contain what we call splenic cords. Splenic cords, these are just tissues made up of reticular connective tissue. Reticular connective tissue is a tissue that also helps in trapping germs. Okay. Aside from these splenic cords, we also have sinusoids. These sinusoids, they are also within the red pulp, and these sinusoids have a very special function, a function that we can appreciate in these images here. Okay. These images, they can revise what we've just covered. Say that the hilum, the splenic artery, we go off branches. We said one of the branches, the trabecular artery, it will enter into the spleen, give off a central artery that will be surrounded by a sheath containing T cells. Okay, we already talked about that, and we say the function is just to allow targeting pathogens. Okay, then we can see that in the red pulp, we have what? The splenic cords made up of reticular connective tissue, but also we have sinusoids. These sinusoids, they are blood channels that are very unique. They have basically spaces that can allow the red blood cells to leak out into the splenic tissue. Once red blood cells leak out, eventually they'll come back into blood, but if a particular red blood cell is worn out, if it has reached its lifespan, that red blood cell may not be in position to come back into the saturation. It will be stuck in the splenic cords, and it will be destroyed by the macrophages in the splenic cords. That's why we can conclude and say that the red pulp is a part of the pancreas, of the spleen, that will help in recycling of red blood cells. Okay, so that's the function of the red pulp. It has these sinusoids that can allow leakage of red blood cells into the splenic cords, and normally these red blood cells, they come back into saturation, but if a particular red blood cell is deformed as a result of aging, it won't easily come back into the saturation. It will remain stuck outside here, and it will be targeted by these macrophages. These macrophages, they abandon cells in the splenic cords, and that's why our red pulp is going to be very relevant in recycling of red blood cells. Okay, so all this is the white pulp. We've explained its relevance. This is the white pulp made up of a central arteriole. This periarterial lymphoid sheath made up of T cells, and then these follicles that are made up of B cells. The relevance of this is immune surveillance. After those germs being targeted, this blood comes to enter the sinusoids, and normally these sinusoids allow the red blood cells to leak into the tissue, and then later on those cells can come back into the blood, but if at all they are deformed, they remain stuck there and they will be destroyed by the macrophages. Okay, so that is the normal functioning of the spleen. After all the germs being cleared off, after the deformed cells being cleared off, the remaining blood is going to comfortably come back into the venous system and be taken out by the splenic vein, as you can see here. Okay? So that's a unique function of the spleen. Yes, Moses?
Yes, I have a question, Doctor. I'm requesting to know whether is there a similarity between the parasympathetic and the sympathetic innervation of the pancreas and the spleen, or they are somehow different? Because there is somewhere where we see that the pancreas is innervated by the cranial nerve X, even in the spleen, but the sympathetic stimulation is what is disturbing me. Maybe you can throw more light there.
So Moses, we've not reached there. You pose that question at the end, because now we are looking at the structure of the spleen. I've not talked about the nerves anywhere. Okay, you pose that question at the end, Moses. Hope that is okay. Okay, Amon?
Yes, sir. Thank you. I have
have a question.
Yes.
When myofibroblasts contract, do they help in hemodynamic stress even after fetal? Because I read somewhere this action is common in animals more than in human beings. Because fetal life also is where the spleen is involved in cytosis. And also another question, more clarity on recycling of red cells. Does it also occur in the liver? Because there's also some confusing thing. Thank you.
Okay. The in fetal life, the spleen is going to be very important in hematopoiesis, formation of blood cells. Okay, that's the main function of the spleen in fetal life. Okay, in the adult life, we've mentioned the functions, immune surveillance, recycling of red blood cells, but also we've said the spleen can be helpful in cases of hemodynamic stress. Yes, that function is more abundant in the animals, but also in human beings. We have these cells that they're not there for no reason. Those cells, the myofibroblasts, they always allow some bit of contraction of the spleen so that blood can leave the spleen to prevent hemodynamic stress. Okay, so that function, it also applies in humans. That's why some literatures will say that the spleen is also known as a natural blood bank, because if you excessively bleed, your spleen can somehow contribute to replenishing the blood that is lost. It can contribute to that because of the fact that it can be made to contract to push some of the blood that it contains to other parts of the body. Okay. Then you ask if the liver is also relevant in hematopoiesis before birth. Yes, it's important in hematopoiesis. The spleen, the liver, they are all important. The yolk sac, early in development, is also important. So there are many structures that contribute to hematopoiesis before birth. But after birth, the main structure that will help in hematopoiesis is the bone marrow in your bones. Is that clear, Amon?
No, sir, I meant the liver. Does it also help in recycling blood cells?
Yes. Worn out red blood cells can be recycled by macrophages in the spleen, but also macrophages in the liver. Yes, it helps.
Doctor, thank you.
All right. Okay, so going forward, we've looked at the normal internal structure of the spleen, and we say that is very important in making you appreciate the functioning of the spleen. Some clinical correlates here. It's possible for the spleen to rupture. This can rupture, for example, if there is trauma as a result of maybe severe injury due to contact sports. People involved in those contact sports, it's possible for someone's spleen to be injured, but mostly trauma is going to be as a result of motor vehicle accidents. Okay, accidents can make your ribs to fracture. Once the ribs fracture, whether 9, 10, or 11th rib, those rib fragments can easily do what? Injure your spleen. And of course, since it's a reservoir for blood, obviously once there is rupture, there is going to be severe internal bleeding. So that's why this is a medical emergency, and these patients have to be operated to prevent hemodynamic shock. There are some other factors that can lead to rupture of the spleen. There are some infections that can make your spleen enlarge and then be at a risk of rupturing. Some of those infections include infectious mononucleosis. It's an infection caused by Epstein-Barr virus. That virus can easily increase chances of splenomegaly and then later splenic rupture. Okay, that Epstein-Barr viral infection. Okay, then clinically, these patients that present with a ruptured spleen usually are going to feel pain around the left shoulder. Why? Because we know that the spleen is close to the diaphragm. We know that, and the diaphragm is innervated by the phrenic nerves. We know that also. So this blood that's going to be coming from the spleen, it can irritate the diaphragm. Once it is irritated, these sensory signals are going to be carried by the sensory fibers of the phrenic nerves towards the brain. And we also know that from the shoulder area, we have the supraclavicular nerves that pick pain signals towards the brain. So normally these nerve fibers that innervate the shoulder, the supraclavicular nerves, also are going to come from these same spinal cord segments. So whenever pain signals are relayed from this area and from this area towards the segments of the spinal cord and then towards the brain may not easily identify or recognize the exact source of pain. That's why these patients will not only feel pain in the left upper quadrant, but also they will feel so much pain around the left shoulder because of that explanation. So that is called the KO sign. So is seen in those patients with ruptured spleen. Splenomegaly, just from the word, big spleen. The spleen can enlarge. Because of many factors. Most of the cases, the enlargement is as a result of liver cirrhosis. If a patient has a diseased liver as a result of, let's say, viral hepatitis or chronic alcohol consumption, that diseased liver, of course, will prevent easy flow of blood through it. And some of this blood can go back into the portal vein. From the portal vein, blood will go into the various tributaries of the portal vein. And one of the tributaries of the portal vein is the splenic vein. So that's why it's possible for this blood to overload the splenic vein and then later overload your spleen, resulting into enlargement of the spleen in patients with liver cirrhosis. Patients with these types of cancers, leukemia, lymphoma, all these cancers can easily result into an enlargement of the spleen, because normally the immune system is going to be responding to these cancers, and obviously we have immune cells in the spleen, and once they proliferate, the spleen is going to become enlarged over time. Some kids with malaria can present with an enlarged spleen, because we know that pathogen that causes malaria, the Plasmodium falciparum, it can easily injure the red blood cells, and then once they are deformed, they can easily block the blood vessels of the liver, thus resulting into trapping of blood in the liver. Sorry, in the spleen. Okay. So that's why some of those kids can have splenomegaly. Then I've mentioned about this condition, infectious mononucleosis, or what you can also call the kissing disease caused by the Epstein-Barr virus. It can also increase chances of splenomegaly, and then splenic rupture, as I explained. So in patients with splenomegaly, of course, I say the craniocaudal length is going to be more than the normal. If it goes beyond 12 centimeters, that's a sign of splenomegaly. If it goes beyond 4.6 centimeters, that's a sign of massive splenomegaly. Okay, so, and also you can see that the spleen is going to be enlarging towards the pelvic cavity. Remember, its lower end is pointing towards the pelvic cavity, as you can see. So whenever it enlarges, it's going to be enlarging towards the pelvic cavity. That's another important thing to note. Okay, so to further appreciate the clinical qualities of the spleen, it's important to revisit how it is formed. But this it's going to be covered shortly. Just give me just a few minutes, around 3 or 5 minutes, sort out this issue. Then We come back and look at the embryology and the important congenital abnormalities. Just 5 minutes. Okay, I'm back. Is the screen back that side? Can you hear me?
Yes.
All right, that was just a small break. Let's finish up. Embryology of the spleen. Yes. What do we know? Anyone? Where does it come from? Anyone? Where does this organ come from?
Arises from the mesoderm layer.
Okay, so it's an organ derived from mesoderm. Okay, so basically, usually during development, okay, we know that as the gut tube forms, of course, the gut tube or the alimentary canal tube, we know that it forms around the 3rd week, 4th week of development there. So whenever the gut tube forms, it has a connection to the anterior body wall and a connection to the posterior body wall, okay? And this connection to the anterior body wall is called the ventral mesogastrium. The ventral mesogastrium. And this connection to the posterior body wall is called the dorsal mesogastrium, okay? So normally during development, within the ventral mesogastrium, we shall have mesodermal tissue of the septum transversum forming the liver. We covered that last time. Then within the dorsal mesogastrium, we have mesodermal tissue that will be coming together to form the spleen within the dorsal mesogastrium. This happens during the 6th week of development. several condensations of mesodermal cells come together in the dorsal mesogastrium to form the spleen. Of course, we know that during development, this gut tube has to rotate. We know the stomach has to come to the left side. The liver has to go to the right side. So because of the rotation, this originally median position of the spleen is going to change so that your spleen can shift towards the normal anatomical location or position, and that is the left upper quadrant. That's why it's going to shift during the rotation so that it can go in its normal anatomical position. Okay. Of course, after going to its normal anatomical position, the mesenchymal cells within it, they are going to differentiate to splenic pulp. The splenic pulp is that parenchyma of the spleen that contains the red and the white pulp. All these arises from the mesenchymal cells. Okay, the connective tissue, okay, within the spleen, it's going to come from this mesenchymal tissue or cells. The splenic capsule is going to be formed by these mesenchymal cells. They're going to differentiate to give rise to all of these components of the spleen. Okay. During development, we've said it's going to form within the dorsal mesogastrium. Okay, and we said normally the tube rotates so that your spleen can go to the left side, as you can see. As it goes to the left side, this dorsal mesogastrium is going to differentiate to give rise to the various supporting structures of the spleen. For example, this connective tissue here that we shall later know as the gastrosplenic ligament, and then this one here that we shall later know as the splenoid ligament connecting your spleen to the kidney, a ligament connecting your spleen to the stomach. All these are derived from the dorsal mesogastrium during the rotation. They have to form so that your spleen can be held firmly in position. Okay. There are a few congenital abnormalities that are related to this development. Number one, there's what we call asplenia. Asplenia means congenital absence of the spleen. This patient is not going to have a spleen. There will be no spleen. Normally, you can see in this CT image, there should be a spleen on the left side, just close to the left kidney. It should be there, but in some cases, it's going to be absent. You can see on the right side we have the we have the liver, we have the right kidney. On the left side we have the left kidney, but the spleen is missing. That can happen or it can be appreciated in some neonates. And whenever it happens, obviously you know that there will be a very high chance of infections in this neonate because the spleen, you know, it has an immune function in the body. So absence of the spleen increases chances of infections, many kinds of infections, pneumococcal infections and many others. All that increases chances of increased mortality in such patients or neonates that present with asplenia. There will be a poor prognosis. Chances of these kids thriving is going to be less because of the fact that they don't have a spleen that has an immune function in the body. But also, such neonates also tend to have other abnormalities, mostly heart abnormalities. Having these heart abnormalities also increases chances of this kid not surviving. Okay, so that condition is called asplenia. Then we have what we call polysplenia, many spleens, multiple spleens. They are going to be multiple. Close to the kidney, you can see those different tissues. They are tissues of the spleen. They are going to be multiple, and we shall call that polysplenia. Because if at all the mesodermal tissue doesn't condense together to form one solid organ, it doesn't condense together, it results into what we call polysplenia. Okay. In some abnormal cases, it may be bilateral. You may have some of the splenic tissues on the right side. That's not so common. Most of the times, these multiple smaller splenic tissues, they are going to be on the left side, close to the left kidney. Okay? That is polysplenia. All these problems basically occurs because of the genetic mutations. Normally, during development, there are some genes that always have to produce growth factors that have to allow normal development. So if there are gene mutations, it's possible for those genes not to produce growth factors that have to allow normal development, and that can lead to these congenital abnormalities. It's possible to have or to have multiple splenic tissues outside the normal location of the what? Of the spleen. Okay. We know that the spleen has to be within the left hypochondriac region. Okay. It's possible to have small splenic tissues or nodules of the spleen separated from the spleen itself. These can be in different parts of the body. They can be within the pelvic region. They can be within that great omentum. They can be within the splenorenal ligament, within the gastrosplenic ligament, within the tail of the pancreas, and that always confuses. You may think that there is a tumor of the pancreas, yet it's just splenic tissue within. Okay, most of the times they can be close to the hilum of the spleen. In most cases, they are close to the hilum of the spleen. They are round ovoid structures or nodules. Okay, that is accessory spleens, or what we call splenuclei, or supernumerary spleens, or splenios. All this means the same. These can form if at all the mesodermal tissues don't condense, and then if at all they don't condense, it's possible for them to easily reside in different anatomical locations in the abdominal cavity. Okay, if that happens, we call that accessory spleens, or spleninculi, supernumerary spleens, or splenios. So always it's important to identify these splenic tissues or nodules. These patients may not have symptoms, but it's always important to identify these splenic tissues because if there is any disease of the spleen, let's say cancer of the spleen, and let's say it has to be removed, this cancer will not heal because there will be other splenic tissues in other parts of the body outside the normal anatomical position or location. So that's why it's always important to always critically examine the body structures. If there is any inconsistency in the tissue or in the organ structure, you always have to be keen to note out these different abnormalities. Then there's what we call a wandering spleen. A wandering spleen, this is a spleen that's going to be fully formed. Okay, there are no nodules around. It's fully formed, but it's in a wrong anatomical location. The causes could be developmental laxity of the ligaments, those connective tissues that we talked about. If they are weak, okay, as a result of incomplete development of the dorsomesogastrium, it's possible for the spleen to easily wander or descend inferiorly to be located in other parts of the abdomen or in the pelvic cavity. If there is that developmental weakness of the ligaments as a result of underdevelopment of this dorsomesogastrium, this can occur. It can occur also with age. As we age, our body tissues weaken. Okay, so those supportive elements can weaken with age. They can weaken if a patient has splenomegaly. Okay, if the spleen is heavy, it can't be held in its anatomical location. It can easily descend downwards. There's trauma, extreme weight loss, weak abdominal muscles, and excessive gastric distension can lead to spleen slightly residing out of its normal anatomical location. So all those risk factors that can lead to this condition. Whenever this happens, there is a very high chance of torsion to occur. Torsion can easily occur because our spleen is going to be wandering within the abdominal cavity. It should be up here, okay? So since it is wandering within the abdominal cavity, remember it has connective tissues that always are connected to it, okay? There are those connective tissues connected to it. So because of the fact that it's wandering in the abdominal or in the pelvic cavity, it's possible for this organ to twist upon itself. And once it twists, that's what we call torsion, splenic torsion. And once there is torsion, the blood vessels that supply the spleen are going to be occluded. If they are occluded, the tissues of the spleen will start dying. They will undergo necrosis. Okay, so always it's important to identify these abnormalities radiographically so that those complications can be prevented. So you can see these images. All those are coronal CT images showing you the wandering spleen that is outside its normal anatomical position or location. So sonographically, it's possible to see the spleen, okay? Though, of course, there are some limiting factors. You can see that our spleen, we said already that it's going to be situated close to these ribs, these lower ribs. So these ribs are going to act as blockers. They are going to basically obstruct clear visualization of the spleen, okay? And always there will be some bit of shadowing, acoustic shadowing, because whenever the sound beam hits these bones, that beam will not allow easy visualization of the spleen, but instead there will be shadowing, preventing clear visualization of your organ. So there's always that those limiting factors, but of course you can easily tilt your probe through the intercostal spaces to easily scan your spleen. For example, here the intention was to scan in a sagittal scanning plane, but you can slightly tilt your probe obliquely to the right side so that it can be in line with the intercostal spaces, this intercostal space here, so that the beam can smoothly go through your spleen, slice it so that you can see that longitudinal section of the spleen. Okay, so this is your spleen here. That's how it appears sonographically. Of course, up here, this is the diaphragm, though not fully shown, but that's the diaphragm. Okay, this patient is lying down. It could be in the spine position. It could be on the right side of the body, or in what we call the right lateral decubitus position. And the structures towards this side, they are the ones that are more superior. This is towards the head of the what? The head of the patient. This is towards the feet of the patient. So this structure that you see here is the diaphragm, which is situated above and posterior to your spleen. Then, of course, this is your hilum of the spleen. This image is further showing you the longitudinal view of your spleen. If you obliquely position your probe in the intercostal spaces, you can see that longitudinal view of the spleen. And it's the one that is always used to measure the craniocaudal dimension of the spleen to see if it's in a normal dimension. So the dimensions can increase in patients with splenomegaly. Okay, so you can see that is your spleen there. That is the hilum. We have the vessels going through. Okay, up here, superior, you have the diaphragm, though it's not fully shown. But this is your diaphragm above and posterior to your spleen. Below, these are the vessels. And of course, there is some gas in structures. These structures here indicating these are basically intestinal structures because of this gas that you see here. Okay, if you slightly tilt your probe within the intercostal spaces, it's possible to appreciate the kidney also. Remember we said your spleen is close to the left kidney. So it's possible to see the left kidney when you scan the spleen, and you can see it here. Okay, this is the diaphragm, of course, as we've said, though it's not fully shown. This is your spleen here, and you can see that below it, slightly posterior, we are seeing the kidney. It's coming into view. The left kidney specifically, it's coming into view in this sonogram. These images here are still showing you the same orientation. To appreciate the spleen, we say the spleen, it's going to be close to the diaphragm, above and posteriorly, and that's why in these images you can see this diaphragm clearly above and slightly posterior to your spleen. Okay, this is the diaphragm here. Okay, the left kidney, of course, it's seen below, it's slightly below the spleen, and of course it can be clearly visualized in this image. Okay, these two structures, they appear differently. This is appearing a bit bright. Okay, this is appearing more darker. Okay, so there is a difference in the texture of these structures. Of course, there are more terms that you will learn as you continue with ultrasound. Hemotexture, homogeneous, hyperechoic, isoechoic. I don't want to use them now because you've not learned about them, but just know that the spleen, it's going to structurally look different from the kidney. It's slightly bright. This is more darker. Okay, so that can help in distinguishing these two. But also, obviously, if you see the diaphragm close to this structure, obviously it will be the spleen. Okay, you can't easily miss it. In this image, what are we seeing? We are still seeing the longitudinal axis of the spleen. This is the diaphragm up here. Okay, well, this is towards the head of the patient, towards the feet, this side, anterior, posterior. Okay, these are the abdominal muscle, this is the abdominal wall. Okay, of course you have the ribs here. That's why you have some shadows within this image because of the ribs that are close to the spleen. This is the diaphragm here. This is the hilum, okay, where structures are going to pass. The vessel that is wide, that is the vein. Veins are always wider, have a wider lumen. So you have the splenic vein there. Okay. We are seeing something here. We are seeing a structure having the same structural appearance like the spleen, close to the hilum. Obviously, you can conclude that this is an accessory spleen. It's a splenic tissue that is detached from the main organ. Remember we said these tissues or these nodules are commonly going to be seen close to the hilum. So it's what you are seeing in this image here. Okay. So basically, those are a few points I can mention regarding the spleen, the gross anatomy and the clinical anatomy. That's what I can summarize and mention about. Okay, do you have questions before we end? Yes, Moses. Very fast.
Yes, thank you. I have another question. Is it true that during embryonic development of the spleen, we see that before in the embryonic development of the midgut, there is herniation? So is it true that that herniation may further spread to the spleen, or it's separate?
So during herniation, it's the midgut loop that herniates. Okay. And we know the midgut gives rise to small intestines. So technically, it's the small intestinal coils that are herniating. Okay, and of course, you learned that when those coils fail to return, they may be trapped in the cord, the umbilical cord, resulting into an omphalocele. This omphalocele, it's going to contain coils of the small intestines. Rarely can it contain the spleen. Okay, in some abnormal cases, can contain the spleen, part of the liver. Okay, but it's going to mostly contain the coils of the small intestines. Moses, is that clear?
Yes, doctor.
All right, so Flavia, very fast. Flavia?
Thank you, sir. Inquiring, in cases of asplenia or splenomegaly, how is the function of the spleen be compensated?
All right, so if there is need to remove the spleen, let's say because of cancers, or is this patient is going to be put on drugs, antibiotics, and various kind of drugs that will always limit infections. Of course, there are other structures of the body that have an immune function, the bone marrow, the thymus, and many others, the various lymph nodes. They can contribute to the immune function of the body, but additionally, this patient can be given drugs that can be used for a long period of time to limit infections. Okay, so that's what is done. Drugs are used to limit these infections. Is that clear to you?
Yes, sir. Thank you.
All right. All right. Lastly, Stephen. Stephen. Oh, he's not speaking. Mariette. Let's get the last question from Mariette.
Thank you, sir. May I request for more elaboration or clarity on the innervation of the pancreas?
So I didn't talk about the innervation of these structures because it's not clinically important, but understand that these organs are innervated by the autonomic nervous system, the sympathetic and the parasympathetic. Okay. Your pancreas is mostly going to be controlled by hormones. Hormones are going to control the secretion of pancreatic juice. So hormonal control over ways, it's more important than the neural control. Okay. But yes, there are nerves like the vagus nerves that are going to always come in to innervate your pancreas, allowing more pancreatic juice secretion. Okay. But hormones, there are several hormones from your GIT, hormones that are going to control the secretion of contents from the pancreas. Okay. Those hormones, I told you to read about them. I don't know if you tried to. So that's how I cannot marry the control is more important of representatives, and I think I don't have Esther's number. I'm going to share to David. David, you send to Esther so that Esther can send to the other groups. Okay, so with that, let's end the session here. Remember, we are going to have vivas on 31st to examine the digestive system and the cardiovascular system. Okay, so please prepare so that you perform well in those vivas because they're going to contribute to your progressives. Okay, with that, let me end the session. Have a good day. A nice revision and discussion.